Section, we're going to talk about some assorted topics in healthcare. We're not going to be covering the entirety of Chapter 7, just touching on a few of the different sections. So anything on the exam will just be the things we talked about in this lecture. Nothing that I don't mention that's in the book is not going to be tested. So we're going to start by looking at how healthcare has improved the health of people within the United States, so the effect and the improvements of healthcare over time. We're going to very briefly look at healthcare around the world, just the different health insurance methods and how healthcare is delivered. This will be very brief overview of that. The next section, we'll look at information problems and some of the externalities of the market for healthcare and some potential solutions. And then at the end, I've gotten rid of some of the debate over healthcare policy in the United States, but I've kept some of it and then added a little bit to it. So different topics that affect healthcare that, in my opinion, aren't frequently enough talked about. So back in the late 1700s, England had the highest level of income per person of any large country in the world. Lifespan for English people were one of the best in the world, and in general, their income was so high they had, the highest standard of living. But still, their lifespan was short compared to today. People were poor compared to today, and they suffered from a lot of diseases like cholera, yellow fever, dysentery, smallpox that people don't get nowadays. Now, this is true not just in England, but for the rest of the world, where life expectancy, the quality of healthcare, these things have vastly improved over time. Now, just looking at the United States, currently today, our healthcare expenditures are higher than anywhere else in the world. And hopefully through this chapter, we'll figure out some of the reasons why. One is there's the high quality of healthcare. It's much better today than it was in the past. The way we pay for our healthcare is different than in other countries. And demand may be higher for healthcare in the US. And just to define healthcare before we move on, I know we all use healthcare, but for definition, what we'll be working with is healthcare is considered goods or services, so things like prescription drugs, consultations with a doctor, surgeries, things like that, that are intended to maintain or improve a person's health. So much news today is so negative, let's look at something positive right here. See the increase in the health and the life standards of people in the United States. So comparing 1850 in the US to 2015. The life expectancy of birth of someone born in the year 1850 was 38.3 years. Life expectancy at birth at someone born in 2015 is 79.6 years. So this is a vast improvement. The average height of adult males, which signifies how, not just how healthy a person is, but how good their childhood was and how nutritious their food was, whether they had enough or whether they, had to go without. The average height was 5'7" in 1850. It's now 5'9.5". So we see people are able to eat more food and more nutritious food that helps them grow. And there's a lot of other good things associated with, people growing taller over time. And again, finally, let's look at infant mortality. So the death of a child that's less than 1 year old. In 1850, it was 228.9 out of 1,000 live births. That's hard to imagine in the United States today. And the number in 2015 was only 6.2 out of 1,000 live births. So over the last, couple centuries, there's been incredible advances in health outcomes for Americans. And this is something we've seen largely around the world. Some of the reasons are an improvement in nutrition. People have more food and more nutritious food, a more varied diet. Another cause is the improvements in public health. So these were really big in the late 19th and early 20th centuries. So we had better sanitation within cities, better food distribution, food quality standards, things like that. And there's a feedback from better health to higher incomes to better health. What I mean by that is that as people grow healthier, they're able to earn more. If you're looking at physical labor, obviously you need to be healthy in order to spend all day picking things up or however using your body. Taller people that have, more nutritious foods in childhood are going to generally be stronger and better equipped for manual labor. Also, when you're looking at more white-collar work, something where you're using your brain, obviously being healthy is going to help you with that as well. So There are important differences between healthcare systems in the United States and those of other countries, and between other countries in the world. And this is both for who provides the healthcare, whether it's public or private, and who pays for the healthcare. Now, most healthcare in the United States is provided through private firms and is paid through health insurance. So, health insurance is a contract under which the buyer agrees to make payments or premiums in exchange for the providers agreeing to pay some or all of the buyer's medical bills when those arise. So insurance payments can be fee-for-service. In fee-for-service, doctors and hospitals receive a payment for each service they provide, rather than like a monthly subscription. Or you can have health maintenance organizations, or HMOs, where doctors receive a flat fee per patient. I don't want to spend too much time focusing on health insurance, the difference between different types of health insurance. But I will note, here's a graph showing the percentage of the population on different types of health insurance providers. The vast majority, or not vast majority, but the largest group is the employee-provided insurance, which is over 50%, so it's a slight majority. Then we have Medicaid at close to 20%, Medicare maybe about 17%. So combined, we have a pretty large presence of government-provided health insurance. Then we have individual insurance, so not provided through your employer, but maybe for like people that own small businesses that get insurance on their own. Then there's some military health insurance and about 10% of the population who's uninsured. Again, this is 2014, so it's a little bit out of date. As time goes on, healthcare is becoming a more and more important part of the U.S. economy. So now the number of, or the percentage of workers in each state that are in healthcare has been increasing substantially. So looking at the figure here on this slide, in panel A, so 1990, the largest source of employment for most states was either manufacturing or retail trade. And of course, Nevada has accommodations, which shouldn't be surprising with Las Vegas. In 2000, that began to change, and we see North Dakota and New York, where healthcare became the largest employer. And by 2014, we see for a majority of states, healthcare has become the largest employer. And not just is this trend in the past, but it's continuing. So the Bureau of Labor Statistics anticipates that 13 of the 20 fastest growing occupations over the next 10 years are going to be in healthcare. We see a lot more people entering healthcare and providing healthcare because there's a much greater demand for healthcare than there was in the past. Now, there's several different types of healthcare systems in other countries that are alternative to how the United States does healthcare and health insurance today. And this is something I just want to briefly touch on. Versus Canada, they have a single-payer healthcare system. So basically what a single-payer system is healthcare is still provided by private firms. So you still have doctors, hospitals, MedExpress, things like that, providing the actual healthcare. But the services that are being provided in those places are paid for by the government. The money comes from taxes. So all the insurance that's actually paying for it, or what would be like the private insurance we have in the United States, is coming from the government. And they're the only ones that provide that insurance. Japan has a universal health insurance where every resident is required to enroll in some sort of insurance. So it can be a nonprofit health insurance, or it can be the government's program. And individuals, in this case, have substantial copays. Another option is the United Kingdom, and they have socialized medicine. So this is a healthcare system under which the government owns most or all of the hospitals and employs most or all the doctors. So you basically have the government providing healthcare and then also paying for healthcare. These tend to be used interchangeably by people in the United States, both for and against more government involvement in health insurance and health care. So it's important to just be able to know the difference between socialized medicine, where you have the government providing the health care and paying for it, versus single-payer healthcare systems, where it's still privately provided but publicly funded. Now, your textbook has a big table comparing health outcomes across several countries. So you have the United States, Canada, Japan, the UK, and the OECD average of advanced countries. Now, there's a lot of problems with comparing across countries. And again, something I just want to highlight. So your textbook lists data problems. So countries don't all collect data the same way. There's problems with measuring healthcare delivery. So quality is extremely hard to measure. As someone whose research area involves a lot of looking at healthcare quality, very difficult to try to measure and measure consistently across time. We have substantial lifestyle choices that are different between the United States and other countries. Part of it is our frontier history. So we have much higher gun ownership than other countries. We are, maybe more prone to violence. If you read the book Albion's Seed, it's about how different groups of people in England settled in different areas in the United States and how those areas reflected the culture from England. The Appalachian Mountain areas was settled by people from the Midlands, and they were clannish. They tended to violence, and we see this reflected in those areas, for centuries after they were settled. So see this more than in other countries. And there's problems with determining consumer preferences. So people aren't faced with the prices in any of these systems. They're not paying these things out of pocket. Another thing I want to touch on that is important for life expectancy and the difference between countries. So the actual births themselves, how they're counted, is tricky. So in the United States, mothers tend to refuse what's called therapeutic abortion for health problems with child compared to European countries. So for things like trisomy and ectophaly, I think I butchered that pronunciation, other health problems that, for instance, in France, there's a very small number of children born with these issues that you would expect much more because of the older age that French women tend to have children at. It would suggest that there'd be a much higher rate of these in the population. But we don't see that because of prenatal screening and the therapeutic abortions that we see much less of in the United States. So this ends up lowering the United States life expectancy. So there's a ton of different things on a cultural level, different things with how people live, and just data gathering problems that make it very difficult to compare across countries. So moving on from differences between countries and just looking at healthcare in general and some of the problems with healthcare. So this section will look at information problems and externalities within healthcare. So we'll be using some of the things we talked about in previous chapters to understand this. So the healthcare market is characterized by what's called asymmetric information. What asymmetric information means is that one party in an economic transaction has less information than the other party. So one person knows exactly, the quality of the good or service, what exactly the good or service is going to be, something like that. Much more information than the other side of the party, or the other side of the transaction. Now, this can lead to what's called a market failure. Remember, market failure is the inability of the market to maximize economic well-being. This may be because with asymmetric information, people don't engage in transactions that they should. They think that the good or service is of lower quality, or it's not going to meet their needs, when in fact it would meet their needs. Or it could be the opposite, that they end up purchasing something that's much lower quality than they imagined. And both of these are going to be problems that are going to cause market failures. Now, the two main forms of asymmetric information are adverse selection and moral hazard. And we'll talk about both of these in turn. So the first one we'll talk about is adverse selection. And we'll begin this with a metaphor to make it much more concrete. So if you're looking to buy a used car and someone offers to sell you one, which would you believe? That the car is high quality and the seller just happens to want to sell it now for some unrelated reason? Or that the car is low quality, what's often called a lemon, and the seller is just trying to unload their problems on you? If you're offering a low or a moderate price, then only people with low quality cars are going to be willing to sell to you. So someone trying to get rid of this problem. So if you don't have any further information, you're not going to want to buy a car from someone who's willing to sell that car to you. This is the asymmetric information problem. So basically, the person selling the car knows exactly how good or bad it is. They know whether it's a lemon or not. You, the seller, don't know. So you're going to be very reluctant to purchase a car at, a fair price that you're willing to pay, because you think that it's going to be a bad car, that you're going to need to offer them a much higher price if you want to have any sort of confidence that's going to be a decent car. There's a good joke from Groucho Marx that says, "I don't want to belong to any club that accepts someone like me as a member." I wouldn't want to. It's the same thing here. I wouldn't want to purchase a car from someone who'd be willing to sell to me at that price. Well, health insurance suffers from a similar adverse selection problem that we see in the market for lemons. So, the adverse selection here, when one party to the transaction takes advantage of knowing more than the other party to the transaction. So basically what's going to happen is that the people who want health insurance the most are the ones who are most likely to use it. So before there was any sort of individual mandate with the Affordable Care Act that, required people with under penalty from the IRS to purchase health insurance, we had young, healthy people that were willing to forego health insurance for at least some time in their 20s until they were much more likely to need health insurance. But people who are much more likely to get sick, maybe they had a family history of diseases, maybe maybe they were older, maybe they ate less healthy or something like that, they'd be much more likely to purchase health insurance. So we needed high premiums to be able to cover the expected cost, because we expect that most people that purchase health insurance are going to need it. And this can be a serious problem because these high premiums, people with only moderate needs may find that the health insurance now is too expensive, that they're paying too much money in these premiums. So they're going to drop out. What this is going to do is increase the premiums even more, and more people are going to drop out. And this is going to continue in a downward spiral. Now, some people are what's called risk averse, so they're very willing to avoid risk, and they may still, even if they're healthy, purchase health insurance. I would consider myself pretty risk averse. I even purchased life insurance to cover my student loans in case something happened. So I would definitely fall under the risk averse category. But not everyone is risk averse, and a ton of young people in the past were willing to go without health insurance. Now, health insurance companies dealt with adverse selection by trying to lessen the impact. The way they did this, or one of the ways in which they did this, was by excluding pre-existing conditions. So basically what would happen is if you had a pre-existing health condition, had something that would, require a bunch of payments from the health insurer, they would, if you had that already, when the time you got your insurance, they would not cover that. Similarly to like if your house was on fire and you try to get health insurance or homeowners insurance right then, they wouldn't cover the house that's currently on fire. But there is a very normative, and again, this is value judgment, question to whether the gains to society through avoiding this adverse selection by excluding pre-existing conditions outweighs the cost to society through the reductions in health insurance coverage. I'm sure the second I started talking about this, something kicked in the back of your mind, like, wow, that's pretty unfair that people are being excluded, or that these conditions are going to cost them a lot of money, are being excluded from their health insurance coverage. So there's a fairness aspect. And this is more of a normative question. But we see how, through the doing positive analysis, that this is a way to deal with adverse selection. Another way around this, and which was attempted by the Affordable Care Act, was to mandate that individuals carry insurance. Then you have the healthy people that are unlikely to use it purchasing insurance, which drives down the cost of premiums. So another example of that is most states require automobile accident insurance. So it's not just the people who know they're poor drivers or know, they drive to work at 4 a.m. through a rural area, so it's very likely they'll hit a deer. Even people that don't drive that often or drive times when it's very safe are still required to purchase auto insurance. So now let's turn to moral hazard in health insurance. And this will look at the patients, so from the patient side. Well, remember, moral hazard, we talked about this a little bit in the introduction, refers to actions that people take after entering into a transaction. And these are the ones that make the other party to the transaction worse off. Sounds very abstract, so let's look at an example. People with car insurance might drive less carefully because they're financially protected if they're in a crash. Right? So we have these incentives working against something that's good for society. So people might use more healthcare when they don't have to pay for its full cost. So they may go to the doctor when it's not necessary. They may engage in more risky behavior because, hey, they have health insurance, the healthcare itself is not going to be as expensive. They may accept excessive treatment options just because, again, they don't bear the full cost of it. So these actions would increase the cost of healthcare to society, perhaps without providing any substantial benefits. So in this case, we end up with increased healthcare spending without a lot of return on that healthcare spending. So it's not providing much better health. Um, One solution to moral hazard is to make people pay for whatever they're purchasing, make them pay for the negative things that happen, which again has its own sort of cost and benefit. As a somewhat humorous example, when they asked the economist Gordon Tullock about how to reduce um, traffic accidents, he suggested putting a spike on the steering wheel, super sharp, pointed right at the person's heart. While that's extremely risky, and obviously we won't want to do that, what he's saying in theory is that faced with almost certain death from even a fender bender, people will drive much more carefully. You're reducing that moral hazard. Now, this may not be something we want to do. I don't want my steering wheel to have a giant spike on it, but that's the way we should be thinking about how to reduce moral hazard. So what your textbook notes is that the key to dealing with moral hazard is to try to make sure people don't change their behavior too much when they now have, in this case, health insurance. So for patients, they pay deductibles, so the first certain amount of the treatment costs. So they're still paying some money out of pocket. They still bear some cost. And requiring patients have co-insurance. So the patient pays the first, Y% of treatment costs. Again, just so that they're bearing some of the costs associated with these treatments. An interesting study that the Rand Corporation was able to do was they looked at a random lottery in Oregon that gave more people Medicaid that were previously uninsured. And what they found is that people tended to spend a certain amount of money out of pocket. I forget the exact amount. Let's say for sake of the argument, $800 per month, whether they had health insurance through Medicaid or whether they had no health insurance. So people were willing to pay a certain amount, and that's about all they were willing and able to pay. And the textbook talks a little bit about physicians. I don't want to get bogged down into that too much, but one way to prevent moral hazard of them, ordering too many tests and procedures or engaging in what's called defensive medicine to make sure that they're not being or they're not opening themselves to liability for malpractice is to standardize payments for particular illnesses, so they're not encouraged to order too much health care. These can reduce, but obviously they don't eliminate the moral hazard problems. Now let's briefly touch on externalities in the market for healthcare. I think this should be fairly easy to grasp through examples because of how prevalent COVID and healthcare right now is in our minds. So recall that externalities are an external cost or a benefit to a market transaction. So a third party, someone not engaged in the transaction, ends up getting a benefit from this transaction. So we don't have enough or we have too much being purchased. And this results in a market failure. So positive externalities, one example is vaccinations that reduce the chance of others getting sick. Healthy population, they're good for employers. You have fewer sick days. But it's also, remember, the person themselves has a benefit. Employers also get that externality. Other people around you get an externality. They don't have to worry about getting sick from you. There's also negative externalities associated with healthcare. So poor health choices, things like obesity and smoking, are paid for by others. So if more people smoke, more people are obese, what we end up with is higher premiums because there's more healthcare, more services that are actually needed. Or if they're using Medicare or Medicaid, government-provided insurance, then we end up with higher taxes to pay for those, for the increase in services. So let's walk through an example of the effect of a positive externality on the market for vaccines. So in this figure on the right, we assume that people pay the full price for vaccinations, so the P market that we have here. So the demand curve D1 is the marginal private benefit to people that are receiving vaccines. So that's what they actually get from, not being sick, being able to work, things like that, from the benefit that they get from the vaccine. Supply curve, there's just one that's going to stay the same. But remember, because vaccines have a positive externality, the marginal social benefit from vaccines is going to be higher. So that's going to be a demand curve that's shifted out to the right. The difference between the marginal social benefit, so demand curve D2 in this example, and the marginal private benefit, or demand curve D1, is going to be the size of the positive externality. So now the efficient for all of society, that efficient equilibrium, is going to have a higher quantity of vaccinations at a higher price. So what's going to happen in this market is that people are only going to purchase quantity of vaccines that's the equilibrium point Q market, which is lower than the efficient amount. It's going to be too few for how much benefit is being provided to society. So it's going to cause a dead weight loss. Remember, dead weight loss is the loss we have from all the transactions that should take place that don't take place. So we need something to, remember the phrase, internalize the externality. So make a benefit to society, also a benefit for private individuals. One thing we can do is subsidize vaccines. So in this case, if it costs $50 for a vaccine on the market price, but the efficient price is $55, have the government subsidize vaccines by $5, giving each individual or whoever sells and actually injects the vaccine, give them a subsidy to bring the marginal private benefit, the D1 curve, in line with the marginal social benefit. So doing something to encourage more vaccination in order to reach the socially optimal amount of vaccines.